All right, guys, welcome back to the RPE podcast. So today we're going to be talking through ACL rehab. So we'll be using some of the principles that we've talked about previously and just applying it to the context of ACL. So we're very privileged to have Tim on here. So Tim Rowland's going to be blowing our mind on all things ACL, which is good. We got Connor down there as well. So do you just want to quickly say hi, Connor, and then we'll let Tim introduce himself?
Hey everyone, it's good to be back. It's been a little while since we did one of these.
That's right. But we'll be back for a few more now. So
pretty
awesome.
exciting.
And we could have at some stage joining us a temporary co-host who was begging to get on, but then kind of has left us hanging, and that's Kurt. So if you get someone come up later, we might have another person on as well to give the strength coach perspective. But at the moment, we should be pretty well covered by that anyway, with myself and Tim as also the very much a S&C minded folk strength coach as well. So Tim, do you want to give us a little bit of a intro of yourself?
Yeah, sure. Pleasure to be here, guys. My name is Tim, obviously, and I'm a physio and strength and conditioning coach from Sydney. So I did physio first and then a master's in high performance sport because I love S&C just as much as I love the physio stuff. And I guess that's what sort of led me down the ACL rehab path because, you know, being that double background in physio and S&C is perfect for ACL rehab. You can kind of take someone from A to Z with it all. So love that stuff. And I've worked out of a place called Athletes Authority, which I'm sure some people might have heard of. It's a really, really good high performance facility in Sydney that I've pretty much seen ACL clients exclusively for the last 3 years there. So I've really enjoyed it. Love, the art and science of ACL rehab. Really enjoyable, and then had some interesting, results with a few patients non-surgically as well. So yeah, that's sort of a bit of a background of me in a nutshell and my ACL experience.
Nice. So yeah, getting in, did you decide to go the S&C kind of path just so you could deal a bit, you felt like you'd be a little bit better kind of prepared with these higher level functioning kind of exercises or activities, like getting someone?
Yeah. It was a bit of a combo for me. Not only did I want to be better at the exercise rehab side of physio, I genuinely enjoy S&C as well. So I wanted to be, I wanted to be a strength and conditioning coach too. And that's why, I've done that alongside my ACL work. I was, head of performance for a semi-professional rugby team here in Sydney too. But yeah, a big part of it was just being really good at that late stage rehab and return to play and sort of niching myself into that sort of a practitioner that sort of specializes in that area. I feel like if you got the combo of the two, then you're quite good at that late stage and return to play. And then that can be a point of difference for you compared to other physios or other S&C. So you kind of, become a little bit unique in a way.
Nice. So you'll see someone through the whole process, basically.
Yep, that's it. I definitely enjoy the mid to late stage stuff the most. The early stage stuff doesn't interest me as much, but I obviously I can handle someone from the very beginning if needed.
Yep, cool, nice. And if they have their own like club S&Cs or whatever, you're kind of just working in with them, or do you still try to take more of the initiative and the lead on it, or what?
Yeah, it really just depends on the setup of the person and where they're playing at. Some clubs are really happy for you to sort of take the leads on the whole thing and what can't he do and just you run the show. Other clubs are, there's a little bit sometimes more politics involved and they want to be running the show and you just sort of guiding and checking they're not doing anything silly. But so it really just depends on the person. It varies quite a lot actually.
Cool. And also don't forget to plug your other hustle, the PhysioNetwork, along here at some stage. So that's a great resource, and you get lots and lots of things about ACL and kind of sport related exercise kind of resources, research reviews, that type of stuff on there. So remember to link people through to that.
I appreciate it.
So I wanted to use this as like a bit of almost like a ACL what do kind of session today. So because it's very likely to be watched by lots of students. So really just getting that idea kind of how we apply these principles in all the different phases of rehab, what we're kind of looking for barriers wise, and going through like that, what outcomes we're looking for, and then kind of what the research in general says around that. So if you want to kind of go through and maybe just a bit of an intro, you know, we've done our ACL, and you know, initially what's going to happen. So we've been out on the field, we've you know, done a bad sidestep or something like that, a non-contact ACL. Right from the word go, what's kind of going on there, and what are you looking for programming and barriers wise in that first real acute initial phase?
Yeah, I guess one of the most important things, you know, in my time as a physio that I've learned with perhaps the diagnosis of the injury side of things, which is quite an important step, obviously, is, you know, I remember, you know, you learn all the tests in the world at uni and how to do them and that. And it's funny, like with an ACL injury, they often aren't great in those first day or two post-injury at actually telling you, you know, that the hamstrings often spasm right up and protect the knee, and you try to do your Lockmans and you're like, oh no, it doesn't feel too bad, and you know, everything feels okay. And that's happened, you know, a couple of times in the earlier stage of my career where I've felt like the ACL hasn't been ruptured, and gone on, they've got an MRI, and sure enough it has. So I guess like one clinical pearl I've sort of learned is, if the person tells you that, you know, they felt their knee buckle and give way, and their knee then, you know, started swelling up afterwards, and they had a moment of instability, I would almost always assume that there is an ACL and refer them on to get an MRI. So rather than relying just purely on your hands-on tests, I really would listen to the patient's subjective story of how the injury happened, what they felt, and whether their knee started blowing up since, and then, you know, refer on for an MRI if they tick those boxes, and just to rule it out, because quite often you can miss the boat there. So that's sort of that's from the diagnosis side of things. In terms of if we know there is an ACL injury and what to do there, well, for me, like obviously it's quite interesting how people's perspectives have changed about this. And the default response, you know, 5-10 years ago is like, okay, yep, so when are you going to get your surgery done? But when we're sort of learning more now that you know, there is a potential path for non-surgical management of ACL injuries too, and it doesn't work out for everyone. It's not a black or white topic. It's very, very interesting, a lot of shades of grey. But my approach is to work through a period of, you know, 3, 4, 5 months of structured exercise rehab, and see how the person copes, and, you know, try to gradually progress them back towards what they want to do, and see if you can get them back non-surgically first. And that obviously does depend on if there is other concomitant injuries to the knee too. Like if someone's got a bad meniscal tear, a full MCL and ACL, they're less likely to fit that mold and be able to get away without surgery. But if someone's got a clean ACL rupture and they're functioning quite well in the immediate sort of period post the injury, and, you know, they don't have any really strict timelines or rush or anything to get back on 9 months, no matter what, you know, if they're like a professional athlete and the next season starts at 9 months, there might be more of a case for that person. So, okay, let's go the more tried and trodden path and just make sure I'm back in time 100%. But yeah, so like I like to just work through progressive exercise rehab. Sometimes consult with a surgeon if there is other concomitant injuries to the knee, just to get their take too on whether they think surgery would be definitely needed. And then go from there. So I guess that's a bit more around the decision making on surgical versus non-surgical is an interesting one.
I think I can't remember the paper that I read, but recent enough. It's one of those really big studies from from around like Norway or Denmark or something, where it was talking about that, like the biggest predictive factors of like whether or not, because it was going down that copers and non-copers kind of pathway, and then the biggest predictive factors of whether or not those who were copers would stay or not were like, quadriceps strength and concurrent MCL or meniscal injury. So those are definitely things that we need to kind of, I guess, put into that decision making of how's this person going to go. Not that you can't get away with having both a meniscus injury and an ACL and kind of not being a coper, because we've probably all had those patients that have, for whatever reason, had to put off their surgery and they've rehabbed up pretty fine. But I mean, I think it was about a 50% predictive kind of value if they had both an ACL and a meniscal tear, that they would later on go down the surgical pathway. So it was an interesting read.
Yeah, there's a few factors. Some of the key ones, as I mentioned, are if there is a concomitant injury to the knee. What the research also shows is that people who are older and also females were more likely to be copers than younger males too, which is interesting. Another thing that sort of I found clinically is if someone has had like a really high level of neuromuscular function before the injury, they're more likely, in my experience, to go well than someone who, let's say, has done zero strength training before and generally doesn't have great neuromuscular, strength and control in that. And then you've taken away a passive stabilizer in the ACL. They don't even have great active stability. And, those people are generally more likely to not go as well either. And then the final one would be more of the psychosocial side of things. If someone's like super worried about their knee, doesn't trust it, has read all this stuff about how without an ACL, you're going to get osteoarthritis and all this stuff that isn't necessarily true. Those people too, that's definitely another underrated factor in terms of how well someone will go as a coper or non-coper. So there's some of the things I look at.
Cool. Anything there, Connor, to add before I kind of go on to next question?
No, I think you guys covered it pretty well.
Cool. I was going to kind of go now. So, even if we are deciding kind of surgery, the gold standard now is that, having to wait to that quiet knee. So wait until, your swelling's down, you're getting most of your range back, because surgeons really don't want kind of bad outcomes for operating on a knee that's kind of cranky anyway. So it gives us a good chance to possibly even turn someone or give someone a chance who is not going to be a coper possibly into a coper kind of area anyway, or if not, at least give them the best preoperative rehab. So what's your kind of go-to there? My understanding is that, quadriceps strength is a big predictive value of A, whether someone's going to be coper or not, but then B, also the post-surgical kind of outcomes, even long-term down the track. I think one of the papers that we all read before this is really interesting, that that was like a predictive value there of how someone was going to go even 2 years after surgery. So what are your kind of thoughts on that initial rehab phase there, and what we really need to be doing in that first, say, hopefully at least 6 weeks before someone gets surgery? I know, NRL a lot of times it's like, 48 hours, 1 week, but, hopefully we get
couple hours.
Yeah, I know. Yeah, exactly. On the field, on the sideline.
Yeah, no, it's a good question. I like to keep it pretty simple. The three main goals I have leading up to surgery are to reduce the swelling in the knee, improve the range of movement, and then, as you said, work on that quadriceps and hamstring strength. I like to focus on those three things really. And as you said, it's interesting. There's a paper, I think it's by Failer et al. 2016 that shows that even up to 2 years post surgery, if you come in and you've ticked off those boxes, you have better outcomes, which is pretty cool to see. So we as physios can make quite a big impact even before the surgery has happened, which is, a lot of physios think, okay, it's always post surgical that is the focus, but pre-op, some really important things you can be doing. And look, in terms of programming, it just depends on a few factors. So it depends on if they do have a concomitant injury to the knee. So if they have a bad meniscal tear, you might not be able to do the same sort of things as if they didn't. Same with like an MCL too. So let's say, for example, they do have a bit of a nasty meniscal tear as well. They might not like doing too much deep loaded knee flexion. You might have to work in more of a reduced range of movement with them. Or maybe do a bit more open chain focus than closed chain and get a little bit less compressive load through the tibiofemoral joint. It also depends obviously on their training history before the injury. Like if they've never done any S&C before, then you're going to be doing different exercises with someone who has done a lot of S&C before. But really, like there's not necessarily any right or wrong, mustn't do or must do exercises here. It's just picking exercises that the person can tolerate that achieve those goals that we said. So for me, honestly, it looks like quite normal training for me. If someone doesn't have any other serious concomitant injury, I'm going to try to get them squatting, RDLs, like split squatting, just like what looks like a pretty normal, like GPP, general physical prep type program, and get them as strong as I possibly can before the surgery, because we know obviously post-surgery there's going to be a drop in function. So if we can lift that ceiling a little bit so the drop isn't as bad, that's sort of the goal. Yeah.
That's kind of the way we've been discussing and thinking of things. Hey, Connor, has a lot of time been that envelope of function. And it's basically, I guess, there's been an acute injury, intra-articular, it's not going to have a massive, I guess, envelope of function that it's going to be able to deal with. So it's finding, I guess, what are you using? Frequency, a little bit more frequency, a little bit lower intensity, kind of workouts going along there. So kind of getting a little bit more stimulation, maybe tempo kind of to constrain the external load or something that you're placing on it, or kind of it's very individualized, or do you have like a kind of a set starting point that you usually go?
Yeah, I think what you said's great there. You can manipulate many different rehab variables to suit whatever the patient can tolerate. And I think tempo is a great example. Range of movement's a great example. Whether the type of exercise, like open chain versus closed chain, is a good example. Load, frequency, all these things can be manipulated just to make it as sort of comfy for the person as possible. So that's what rehab's all about. It's all about picking what exercises can the person tolerate the best, that's also going to tick off the goals we have. And if you can do that as a physio, you can pick good exercises that suit your goals, that the patient can tolerate and enjoys, then you're killing it as a physio. And that's what it's all about.
Yep. So just with your goals, obviously you've got range of motion as a key goal. You've got reduced swelling and get the knee happy. The other one was the quadriceps strength. Are you strictly measuring strength, like with a dynamometer or force plates or things like that? Or are you just seeing how they move essentially?
Yeah, good question. I definitely like to try and measure strength, but how we do that will vary depending on what you have available, obviously, in your clinic. And after an ACL injury, sometimes people might not like doing, leg extensions too much if there is a bit of laxity happening in the knee and then it feels a bit funny on them. So, that might be one that some people have used in the past, is leg extension strength and comparing it between sides, but they might not like that. So one that I have found that people do generally tolerate really well, that literally anyone can do in any clinic, is a single leg squat, max reps, or weighted single leg squats. Because I don't really generally like doing just body weight single leg squat max reps, because if the person's relatively strong, they'll be able to bang out 30 or so, and you're not really testing strength there at all. So most clinics, they will have like a kettlebell or a dumbbell up to 10, 12, 14 kilos. So you can add that, get them to hold it and do single leg squats to a box at 90 degrees and max reps, and literally anyone can do that. You don't need any fancy equipment or anything like that. So that's great. If you do have a handheld dyno, you can do a quad strength isometric at 90 degrees, which generally the patient will tolerate pretty well too. So yeah, sure.
And so that 90 degrees as well. So you're looking at those, that kind of range. Any particular reason there?
That's what a lot of the research is done for testing. And so you can get normative values that way. And also generally at that position, the ACL would be under less stress if it was there. So it's less likely to annoy the knee in that position too.
Cool. All right. We've had Kurt's joined us now. So it's
there he is.
Let him in. So the big man, he was wanting, absolutely begging me to come on to this podcast. So he said that he'd fail me on my mentorship if he didn't. So I better let him in. So Kurt, you want to just quickly say hi, mate? And you just got to unmute your mic there and turn your video on.
I'm actually driving at the moment.
Oh, that's right. Well, we'll just let you listen, mate. That sounds good. And just pipe in if you have any questions, hey? Cool.
Yeah,
all right.
I can definitely talk. I've just got to be at a cultural day for a soccer team I'm working with.
Nice. That's all right, mate. So we're just covering that early stage pre-op stuff. Yeah, it's been really good. Tim said that basically we're going to be like looking at our main goals of kind of getting that swelling down, getting that range of motion back, and getting as much kind of strength and using like a leg symmetry index, Tim. So, versus because at that early stage, the unaffected leg shouldn't have detrained or anything. So it can be a good thing that we're kind of going towards.
That's a great point too, mate. I that's something I should add. I'd like to take my unaffected side measurements as early as possible for our return to play goals. You know, so as we know, like over the course of an ACL rehab, just because you can't train as normally, it's very likely that even your good side goes downhill a little bit. So if we can take those measurements of your quad and hammy strength literally as soon as possible after the injury, then that makes it more reliable to use as a return to play marker for the affected side later. So that's a good point to add.
Cool. Awesome. Anything to add there, Connor, question-wise or anything before we kind of go on to...
No, not really question-wise. I was just going to mention, the unaffected leg's pretty important, because if that detrains and you're comparing what you've done in rehab to something that's detrained, then potentially you're not getting them back to where they need to be. So it's important to check the other leg.
100%.
And this would probably be the biggest one for that Kurt would see actually. And then as a S&C coach, your role at this stage is really going, what can I do if your physio isn't looking after this, or if like you guys are working together, it's like, what can we do to maintain or even improve the other leg strength? So that way we've got something that we're looking towards like later on down the track that we're comparing to a standard which all the other players are actually at. So that way the person's not going through this, 9 month even, or hopefully less than that, detraining of both limbs basically. So anything in particular, any pearls that you got kind of, Kurt, that you do when you're seeing one of these people to make sure you're keeping that other leg kind of up and really going to what you want as a good reference?
Not necessarily say a reference for the other leg, but make sure you're still actually doing single leg strength work on it, because you will get a crossover of strength regardless. It's just making sure that you're still trying to maintain, obviously, or build that affected leg to then catch up per se. So I don't necessarily use references on the unaffected limb, because I still make sure they're training on it.
Yeah.
So that's probably my biggest point I take away. I guess give here is not to let it detrain. You're obviously going to get some level of detraining, but you can still get in the gym. You can still do a lot of single leg work without having the other leg involved.
Yep.
100%.
And I'd kind of even say here, what I like to look at trying to do is go, I say like, someone's been able to handle a total volume of stress over their training history originally, whatever their kind of, volume load that they would deal with in a certain session is. Now you've kind of cut out what part of what their volume load they'd be able to deal with. So that system is still able to deal with a decent amount. You just have to find a way to be able to kind of slowly edge some of that extra training volume over onto that other leg, so that whole system's kind of total workload isn't dropping down, and same as kind of increasing a little bit of upper. So it's a really good time to work on some upper body goals, that type of stuff, just so you're making sure that the whole system itself and all the energy systems aren't detraining as well. So I think this is this pre-op and then just straight post-op time is a good one to kind of, everything else gets a little bit more training, because that side there can't be contributing as much to the total stressor that the system is having to deal with. That's the way I think of it anyway. Yeah,
nice.
Cool.
And just to add to that as well, it's not just strength stuff that can be added. You can still do cardio work on a single leg. Like you've got different variations where you've got a rowing machine, where you've got the affected limb stationary on a skateboard, a dolly, whatever you want to use, slide board and stuff, or you can actually undo one of the cranks on a bike and still cycle on the left leg only. Like it does, you just don't want to do it too often. Just enough that you're still getting some sort of workload, but not creating such a huge imbalance again.
Yep. Nice. Anything else to add, anyone?
No, that's great.
Cool. So we've unfortunately that we haven't been able to, get them to persuade or dissuade from surgery, or they just needed surgery. We've done a really good rehab bout at them. So they've had their surgery. Is there anything different that kind of very initial post-op surgical phase looks like, Tim, compared to that kind of pre-op, I've just done my ACL?
It's honestly quite similar in terms of the goals of reducing swelling, improving range, and working on quad strength. But obviously the biggest factor here is going to be, the exercise prescription and selection for your quad exercises. You can't just be jumping back into the sort of things you were doing before surgery, because you've obviously had another traumatic event to the knee, which is surgery itself. People always forget that surgery is trauma to the knee, especially when you look at an ACL surgery. I don't know if you guys have ever watched one. It's pretty interesting what they do. I definitely recommend any students listening to watch on YouTube some ACL videos from inside the knee, and how they drive up through the tunnel and create tunnels to slide the new ACL through, and go through bone, and it's quite interesting to watch. So the same goal. So reduce swelling, improve range, and then start getting the quads start getting those quads firing as soon as possible. And for me, in terms of what I like to do for that, I find that people sort of go to these little like inner range knee exercises straight away, but I quite like also using isometric exercises, as in like wall sits, double and single leg. I find that you don't need to just do your only do your inner range quad and straight leg raise type work. I found that, wall sits, double leg, and progressing to single leg wall sits are a really good one that people can tolerate quite well, quite early, because it's isometric. It's in a good position for the knee in terms of sort of range you can get into, anywhere from sort of 90 if you're killing it, through to 145 degrees of that knee flexion. I like to use those exercises. And then another huge one for me is doing hamstring strengthening early. In Australia, we tend to use hamstring grafts for our surgeries more often than not. And I find that people just always focusing so much on the quads in the first couple of months post-surgery, but the hamstrings are often the one that take the longest to come back in the end. So getting into hamstring stuff safely and early is very important. And I would start that off by simply just doing like a prone knee bend. And you can even lift it up with using your other leg to assist it up, and then lower just with the injured side if you don't have the strength to lift it up from, concentrically. But getting into some hammy stuff early, and then also you can still be hammering your glutes and hammering your calves and everything around it. It's just the muscles that'll be the most compromised are going to be quads and hammies, but you should be going ham on your glute work and your calf work and your other leg, and then your upper body, as we mentioned earlier. So that's some initial thoughts around that sort of first 6 weeks post-surgery.
So, because we're thinking, I guess, the main things that are decreasing that envelope of function, or decreasing what your recoverable volume load are, I guess you got like the swelling and all of the substrates that go along with that there, which are kind of all catabolic stimuli. So they're all kind of making it hard for the knee to actually kind of adapt to stuff there. So, and then you also have, I guess, the fact that there's been an acute injury. So you got like pain inhibition and that type of stuff happening there. So you're kind of saying, basically, if we can just find exercises that aren't like what's your idea pain wise there, like what are you kind of allowing to make sure that you're not getting that kind of person fearful or pain inhibition too much happening?
Yeah, it's a good question. I think it's super important to convey to the patient early a couple of things. That one that pain is normal after a surgery. Even just trying to hobble around, you're going to be in pain. So just making sure they understand that it's normal. And then the second thing, that pain doesn't mean that something's being damaged in the knee. And that's a super important message to convey. I think 99% of the general public assume that pain means there's some damage occurring. And if you can just explain to them that the knee is very sensitive, and because it's just had surgery on it, like things are, sort of hypersensitive in the knee, it's going to feel pain when there might not necessarily be anything going wrong, and sort of get them on board with that message, then that's really important part of the buy-in in early stage rehab. Because look, I'm not telling you want to get the patient pushing through, 6, 7, 8, 9, 10 out of 10 level of pain, but just, I'm always happy to work up to sort of a 3 or 4 out of 10. I think there's no worries there. But having said that, if you're not seeing the patient, every day and working with them on their exercises, you don't want to send them away with stuff that's just always, causing them discomfort every single exercise you give them, because then they're less likely to actually do it. So you try to find, a few exercises. One of them might be just to work up to a 2 or 3 out of 10, and then the others they can do without much issues at all. And that's probably a good balance of pushing into a bit, but not annoying them too much, and making them be less adherent with the exercises you give them.
Cool. Yeah. So we know like an adaptive response is going to be increase in muscle mass, hopefully increase in range of motion, all that type of stuff. What's a maladaptive response for us to kind of look out for, to go, hey, I need to change my exercise prescription parameters?
Let's say it's on the topic of pain and swelling. So I'm okay with up to, a 3 or 4 out of 10 pain at the time. But let's say they do that exercise, and then for the next 3 days, their pain has been lifted, a fair bit. That's a sign. That's a maladaptive response. I would want pain to always settle back to baseline within 24 hours. If it goes beyond that, then you maybe just done a little bit too much. And then same with the swelling response. Let's say they have quite a bad swelling response, and things get a little bit puffier and more annoyed, and that holds again for longer than 24 hours. Then that's probably another sign that you've done something a little bit maladaptive, and then the knee hasn't quite been up to it yet. So I'd look for those two things and the persistence of those two things.
Something that I've heard before in terms of getting range of motion back is that terminal knee extension sometimes can be blocked by something called a cyclops lesion. Have you ever experienced those, or are they something that you look out for? And how long do you give someone to achieve full knee extension before you start to worry about that kind of thing?
Yeah, great question. They're not too uncommon, unfortunately. For me, what I normally do is, if I'm hammering knee extension and really working on it, and it's just not budging over a period of several weeks. So let's say nothing's really changed in 3 or 4 weeks, even though we've been working at it, it's still not that close to full range. Then that's when I start scratching my head. So if you're doing the right things, you're working on it consistently, the patient's adhering to the exercises, and it's really not changing at all over a period of weeks, that's the red flag for me to go, okay, we're doing our part here. We're doing everything we can. What's going on in the knee? And then that's when we can go for a referral to get some imaging, or to even see the surgeon again. I might try to get them back in for their post-surgical appointment a little bit earlier if I'm worried about them. They might have one upcoming in a couple of months, but if the knee hasn't budged in terms of range in 3 or 4 weeks, even though you've been working hard at it, then I might try to get them to see the surgeon a little bit earlier. So that's the sort of red flag that I look out for there. Yeah.
Cool.
What I'd like to maybe spend this last 5 minutes covering, just to round off this early phase stuff before we get into the more fun stuff, would maybe be the possible kind of use of, well, we're knowing, say, to get a muscle to adapt. So, we know our goals, again, swelling management, pain management, increase quadriceps and hamstring strength. We know to make muscles grow and get stronger, they have to apply some mechanical tension onto it. We need to, we have different ways, applying mechanical tension, getting it to get enough work in that you get some muscle kind of damage happening, or you get that metabolic stress type of thing. So because quite often you've had an injury, you can't handle lots of volume, you can't handle, lots of mechanical tension on it. Do you ever use anything like blood flow restriction training? And then the next part I'd like to also go in would be getting Kurt to kind of go in and say how we get these people in this time to make sure they're still feeling part of the team or the culture, to keep them actually engaged in the rehab process. So if we can kind of chat that in the last little bit.
Yeah, sure. I think blood flow restriction is a very useful tool post ACL. Main reason being, as you said, if we're trying to go for the goal of improving strength and improving hypertrophy of a muscle, but we can't use very heavy loads, then we need to work out, okay, how else can I stimulate that sort of muscle hypertrophy without the load being there as much? And that's where we go for, okay, let's hammer the metabolic stress side of things, and blood flow restriction is perfect for that. So obviously if you haven't heard of it before, it sort of occludes a lot of the return of the blood flow away from the muscle. So you get a buildup of metabolites in the muscle, which is a trigger for some anabolic pathways. So it's super useful to use. I've seen it used many times as well. When I interned at the Sevens, there was a protocol that they used, which I really liked. It was, it was essentially 30 seconds on, 30 seconds off of a weighted goblet squat. Might only be 8 to 10 kilos they're holding, but they're just doing constant tension squats. They're never locking out at the top, and they're going for 30 seconds and then 30 seconds off. And they would do that 5 times back to back, and then take off the cuffs, let the knee, the quads blow up a little bit less, and then have a rest for 2 or 3 minutes. And they would do that again 2 or 3 times. So it's like 3 sets of 30 seconds on, 30 seconds off, constant tension squats. And that was really effective. And you could just see that metabolic stress and then the muscle just blowing up immediately from that, which was really cool to watch. So yeah, if you have it, I'd certainly recommend using it. And if you don't have cuffs, like, look into getting them, because they can be very useful for more than just ACLs too. It's essentially any time where you just can't use high load and you still want to be aiming for strength and hypertrophy, they're useful for you. So for sure.
Nice. And it's like real low loads, like 20%, 1 RM.
Yeah.
Kind of, yeah.
Yep. Even less. Like, as I said, at the Sevens, we had these guys who could squat 180 kilos and, they're holding 10 kilo kettlebell and just doing constant tension squats for 30 seconds and then just going 30 on, 30 off. So you're manipulating the work to rest interval to achieve what you want to get from that metabolic stress sort of pathway as well, which is cool.
Nice. Kurt, do you want to have a little chat on anything blood flow restriction that you've used? And then what I'll do is I'll open up another chat and we can just continue on if everyone's okay for another about 20 minutes maybe.
I don't really have too much more to say with blood flow restriction. The stuff I've done is pretty similar to protocols around, where you change between your reps, like between 30 reps the first set and then short break, 15 reps and essentially 3 sets type of stuff. So I haven't steered too far away from the kind of recommendations around reps with blood flow restriction. So no, I don't have too much to say on top of that.
Yeah, I've used basically the 30-15, 15-15 protocol, or just basically, I think the general premise, the general idea is just getting it basically proximity to failure, getting it close to failure and making sure the muscles burn, and then making sure that you stay within all those parameters that Tim was talking about with irritability later on.